Although the session is entitled Skin Diseases, I'm going to try and make for you, show you the link between food allergy and skin conditions. And before I even start that, I would say that one of the key messages is don't change the diet to fix the skin unless the skin is in absolutely dreadful, dreadful shape and the child has other features to suggest nutritional problems. Don't change the diet to treat the skin. So I have disclosures to make. Johnson & Johnson mentioned in one of the advertisements just there, and other sponsoring bodies are involved in some of this research. And we have research from the National Children's Research Council. The outcomes for this short talk today are, we must concentrate on the early introduction of all foods as the target for every child. Screening and testing them and referring them for testing before they introduce foods is not cost effective. And so I've developed the Nike doctrine, like the logo for the sports company. Just instead of just do it, it's just eat it. It's more effective for families to eat other foods and probably tolerate them than it is for families to avoid other foods after they've had an index reaction in case they have a reaction to something else. We want the foods in the diet just in case, not out of the diet just in case. I'm going to talk briefly about immunotherapy and how to show you how we're doing it with milk and egg and sometimes with peanut already, even though this is just using ordinary foods, not licensed products. We want these foods to remain foods and not be considered like drugs or chemotherapy. In the top panel, the immune system is meant to be looking after protection against bacteria and viruses and parasites and cancer cells, and he has his torch there and he's sweeping along the wall, and all of a sudden bacteria and parasites are irrelevant, and poor old little peanut is getting picked out here. We know quite a lot about peanut biology and botany now, but we still don't know why it is the very severe food allergen that we've all come to know in the last 25 or so years. An innocent bystander for some. I like eating peanuts, but my patients fear it with almost a lethal dread. Up until 2005, avoidance of foods for babies was thought to be the correct advice. Now we knew even before that while we were in this time of avoidance, that the food allergies were becoming more common. So work done originally in England and elsewhere has come up or has challenged this sacred cow, or checked the data behind these findings, and has changed, revolutionized in 2015 how we talk about food allergy. So while avoid was on the road, there was a brick wall as well, and we were never going to get to the promised land of no allergies. So we had to change. And this should show you that this is a paper from England about the randomized trial of introduction of allergenic foods in breastfed infants. And by breastfed, this group actually mean breastfed. They've never had anything except breast milk or water. So relatively unusual, particularly in Ireland, but even in England, it's a little bit of a pure cohort. And they showed conclusively that the introduction of milk and egg and peanut early in the diet of breastfed infants, while they were still being breastfed, firstly, didn't have any impact on their breastfeeding, but also significantly reduced their level of allergies to milk and egg and peanut. The study overall was negative because they also had to introduce sesame, fish, and wheat. And to get 6 new foods into the diet of these children in a 6-week period proved a little bit too difficult, and particularly with the fish and the sesame, because the tahini and the fish were really rather strong flavors for young babies. This data should show, this is a systematic analysis done the following year based around the studies about egg allergy in Melbourne or in Australia and the UK, 6 randomized controlled trials with 3,000 infants, and then the peanut introduction with 1,500 infants. I just want to take you through it quickly. This is the key figure here. In a group of children of normal risk, 54 out of 1,000 might have a risk of egg allergy, although that's a little bit high for Ireland. 100 will be high risk and 500 will be very high risk. And the high risk children there are those with severe eczema. We're going to come back to that. And for peanut, there will be 25, so a prevalence of about 2.5%, and 170, 17% in those high risk infants with eczema. And if you introduce the foods early in these populations, you get 50% fewer cases in the normal risk population for egg in the top panel, 24 fewer cases, 44 out of 100 in the high risk, and 220 out of 500 in the high risk, very high risk. And in peanut, the figures are the same. In fact, even more impressive, more than half, about 2/3 are prevented. And this is data that scientists and epidemiologists like to use. How many people do you have to treat to prevent a case? It's 42 for normal risk infants for egg, 23 for high risk, and we only have to treat 5 high-risk children for egg allergy to get rid of 1 case of egg allergy. And the numbers are nearly as good, 56 and 8 for peanut. These numbers compare very well with the number of people you have to immunize to prevent measles or mumps or MMR, where because the illness is so rare now, the numbers to prevent cases needed is very, very high indeed. Anything below 10 is considered a highly cost-effective intervention. I want to just bring you back to the eczema we're going to be talking about in the next 2 talks as well. This is data from our birth cohort study when I was in Cork. On the left-hand panel, it's more common to have never had eczema, which is the green area, if you do not have food allergy at 2 years. And on the right panel, it's entirely the other way around. Nearly more than 80% of the children who have food allergy at 2 years have had atopic dermatitis or eczema. Now, whether this is due to skin barrier dysfunction and skin being the root of sensitization remains controversial. And large studies recently have not proven that skin barrier augmentation is effective, but there is other work coming, and maybe there may have been problems with those studies. But please keep in mind that eczema and food allergy go together very tightly in young children. Whether they cause one or the other, we're not sure. But it is certainly the case that eczema can be triggered by foods. Whether it's caused by foods, it's probably less certain. This is a very important slide. We're going to come back to it later on. And this is from high-risk children in the United States who were advised to introduce peanut. And on the bottom of on the x-axis, you have SCORAD scoring of how severe their eczema. And a score of over 45 on a SCORAD score is very severe, is severe eczema. You should have 0 as a score for SCORAD. 20 would be mild eczema, really, and 45 and above is severe. And on the y-axis, you have the percentage of children who are peanut allergic. And what I just want to show you is that in children who have peanut introduced less than 6 months, there's really not much difference in the rates of peanut allergy depending on how severe your eczema is. Okay, if it's introduced below 6 months. If it's introduced between 6 and 8 months, there appears to be a significant difference depending on how severe your eczema. And if it's delayed till 8 months, they have the highest rates of all, really including here, even in children who only have mild eczema. So in children with severe eczema, it's actually, that is the key group that we want the early introduction to occur in. Okay, so please do not defer introduction of foods on the basis that a child has eczema. They're exactly the children who need it most. This is from HSE Guidance, Nutritional Reference Pack for Infants. This is the updated version from, I think, 2019, Health for HCPs in the community setting. So I imagine most of the audience today will be familiar with this document. And it even, thankfully, has a section all about allergy in the first year of life. And I've just picked out one table. I just want to make 3 points here. Peanuts should be introduced into the diet from 6 months and included at least 3 times a week thereafter. That's all one sentence. It's not like there's 2 sentences and they're separate. We want peanut in and eaten regularly. It's recommended that other food allergens are also introduced. The evidence is strongest for peanut, and recently evidence or analysis has come out that if we look after peanut, the other foods should be treated in the same way. Peanut appears to be the worst case scenario, and if we get peanut in, we should get the other foods in, including ordinary milk, egg, fish, and other tree nuts in baby-appropriate forms, of course, not large chunks, and they should be introduced in the weaning diet. And what we're seeing now, the cases that we're seeing now with food allergy in babies are the children where the food has been introduced and then forgotten about, and the child has had one or two goes with peanut, or there's a family holiday, or there's some other reason, and the food is not in the diet. These are all healthy foods. They do not make children obese. And in fact, the children who were in the studies from the UK had slightly better biophysical measure by anthropometry than the children who were in the control group, because they're very satisfying foods and the children don't snack as often. So in early, other foods as well, and then all should be just considered as ordinary foods. Now this is controversial, and coming back to the eczema issue, new foods should be put in the mouth and not put on the table for the child to feed themselves. We get an awful lot of referrals where the child has picked up sesame or hummus on a cracker, and then it's a little bit tart in their mouth, and then they just rub their mouth, and then they rub their face, and they're putting sesame into their eyes. If I rubbed hummus into my eye, I think it would hurt and I might get hives. So please, when introducing new foods, especially for children with eczema, where they may have a slightly broken skin barrier around their mouth, the food has to go into the mouth, behind the teeth, and then pull the spoon slickly out. I would go as far as to say that baby-led weaning makes no immunological sense. There may be a social attraction for it, that you're giving a child autonomy. Babies don't have autonomy, and I don't see why they need to be choosing what foods they eat. That's a nice controversial point for discussion. They're not autonomous in any other factor of their lives. The early introduction is not the whole answer, because we have barriers to this. Clinicians and nurses and other healthcare professionals may be worried about a particular infant, but I want to make the point to you that it's much more likely that a child with peanut allergy, with egg allergy, will tolerate peanut than will not tolerate peanut. So we want, if they have one allergy, the other foods should not be avoided just in case. They should be introduced just in case. Families can be very worried because the people who are mothers and fathers now grew up during the era when peanut was like toxic waste, and it was a shame on your house if you had peanut butter in your family fridge. Is it cost effective? No, it's not cost effective to screen. Have we got the logistical support to screen every child before we give them peanut? No, we don't. How often should we do it? In the previous slides, we said that it should be at least 3 times a week. How much is a bit of an issue? The only answer I have for you is enough, whatever the child wants to eat. And the frequency, we think 3 times a week works because that's what was in the trials. We think once a week might not be too much, might not be enough, and probably 6 times a week or 7 times a week is probably overdoing it. And really, we want to put this into the context of dietary diversity. We want children to enjoy all forms of food, not just lived on baby jars and orange squash. So we have got to try and offer them all the foods that they see their adult family members eating. We have developed or are developing decision aids. This is an American slide. Starting to feed my baby with peanut will lower their risk of peanut allergy by 70%, and by egg by 40%. But that's the benefits. What might the risks? Only 3 babies out of 100 have peanut allergy, so 3 of them will have a reaction to peanut. So we have to concentrate on telling people they're likely to be in the 97% than in the 3%. And of 100 children who've had testing done, 5 of them will have a false positive diagnosis test. So we don't want testing before introduction. We do testing in children who come to see us in the clinics, but that's a different population. And of the children who do react, of the 3 babies who do react, 99% of those 3 babies, so over 1,000, there'll only be 1 baby who will have a severe reaction to the introduction of peanut. And that's of the peanut allergic individuals. So please don't let this risk of a severe reaction dominate the advice to the rest of the society. We're having the same problem with side effects with COVID and myocarditis, etc. They are recognized risks, but they have to be put in context. Now, we've tried to get our families to increase their consumption of eggs, and this is a research study still ongoing in Cork, where we're looking at skin barrier protection, and we noticed in the blue bars that I'm sorry, in the blue bars here for egg 25.8 and for peanut 6.5 had only very low levels of introduction of eggs, even though the HSE guidelines were available and were given to families in the Cork University Maternity Hospital. So at their 4-month phone call visit, we introduced a formal prompt saying, don't forget you have to introduce egg and peanut at before 6 months of age. And we got egg up to 61%, and we got peanut up to 37%. That's not a very impressive rise, but it is relatively a big increase. And by the time we got these children out to a year, where this study is finishing next month, we've got 99% are on egg and 96% are on peanut. So that's gratifying because we've had further contact with them, and we're reinforcing what should have been in their parenting diaries already. Egg and peanut and other nuts should be in. This is an intervention study, so this is the intervention and the control groups. We've had a tough time in COVID, like everybody else, with closed clinics and referrals still coming in, children still being born, children still needing weaning. And the time window for introduction of foods, as I showed in the critical slide earlier, doesn't wait for COVID, doesn't wait for anything else. So we pragmatically started seeing children doing virtual phone call clinics with children, 23 egg allergic referrals, and we managed to reassess 21 after 4 weeks. And we advised all of the 22 children's parents to introduce baked egg in a form that's lower level than in Ireland. It's nearly universally scrambled egg or omelette as the first form of egg. All of you will have heard about the egg ladder, so I haven't got a slide of it here, but it makes sense that if somebody reacts to scrambled egg, that they will be tolerant of baked egg forms, and they should not wait until they come to clinic before starting the egg ladder. 21 were assessed after 4 weeks, 4 hadn't done it, and of the other 16, they had started baked eggs safely at home. So there's a 76% initiation of egg ladder use without needing clinic attendance. There was clinic contact, but not clinic attendance. So if you find children coming to your surgeries, your clinics, who are saying that they have had a reaction to scrambled egg, if there's no reason to suspect they've had an anaphylaxis, which is nearly unknown, it's not unknown, it's nearly unknown in this age group, very rare, they should be started on baked egg, starting on the ladder before you come to clinic. And they should also start eating peanut. 22 egg allergic referrals, 4 were already eating peanut, which is great, and 6 were advised to wait for testing because they had severe eczema. Do you remember the severe eczema group may need to be assessed by hospitals first. 12 were assessed after 4 weeks, only half had eaten the peanuts, 6 hadn't done it, and 1 baby refused the peanut. So if we take the 12 and ignore who had and hadn't eaten peanut, 11 out of 12 were skin test negative, were skin tested, 9 were negative and 2 were positive. 1 child had already eaten it, even though he had a positive skin prick test, and we only had 1 allergic child out of 22 or 16 children tested. So peanut can also be introduced at home before coming to clinic if there's no index that they've severe instability during the reactions to egg. Okay, so there was no screening calls, but no testing, and only 1 case of peanut allergy in a high-risk group of 26 allergic individuals, egg allergic individuals. So we're back to just eat it here. Just eat it. We want them to eat the food. Just in the last couple of minutes, I want to talk to you about cow's milk allergy. Historically, the treatment again has been avoidance using soya milk, extensively hydrolyzed formulas, amino acid formulas, and unfortunately, off the internet, goat's milk, oat's milk, and almond milk, none of which is safe or advised. But now we are using the milk ladder for tolerance induction. This has been going on for several years now, but in Ireland, we are well ahead of the curve with getting this started quickly. This is the UK BSACI guidelines, and unfortunately, it says consider reintroduction from 12 months. There's no immunological reason to delay, and this critical slide I showed you earlier showed that delay leads to higher rates of allergy. And then review every 6 to 12 months. That's almost, I think, ridiculous that you would leave somebody 6 months without reviewing how they were going on with introduction and starting with baked milk. In Australia, it's even worse. Avoid all milk until 2 years, and then you have a baked milk challenge, so it's hospital dependent. And if you pass that, you then introduce baked milk. So we think that window of sensitization is being left open for far too long when we can slam it shut by getting milk into the diet. And we've done a randomized controlled trial of 60 cow's milk allergic children, randomized to getting a small dose of milk, a tiny dose of liquid milk, so it's not even baked milk, it's liquid milk, and then, or normal care. Now, the normal care in Ireland is to use the milk ladder. So the intervention is the single dose, and then routine care is using the milk ladder. And I just want to show you that even in the orange bars here, which is the control group who just used the milk ladder, 50% of them were more than halfway up the milk ladder at 6 months. And by 12 months, 80% were up the step 6, and 40% were at step 12, which is drinking liquid milk at 12 months. Of great interest, however, is the group who had the single dose intervention. 73% of them were at step 6 at 6 months, and 30% were finished. They'd grown out of their milk allergy within 6 months, which is relatively super warp speed resolution. The control group had caught up, understandably, by 12 months to step 6, but they still hadn't got to the level of 2/3 being tolerant of milk. And I want to bring you back to this number needed to treat. This number is only 4. So to get rid of 1 case of milk allergy, you only need to treat 4 of them with a single dose and the milk ladder. So it's a highly time and money efficient way of treating milk allergy. And I can tell you it was safe. We had no episodes of anaphylaxis and only 3 minor allergic reactions to milk using the ladders. And they were all to forms of milk that the child should not have been offered. So it's not that the child was reacting using the ladder, it's that some adult made the mistake and gave them liquid milk. So this has 2 conclusion slides. Children who have had even anaphylaxis to milk and or react to the milk dose, the single dose of tiny dose of milk that we gave them that makes 5% react, they can still be safely started on the milk ladder at diagnosis. And if you have children who are reacting to milk, I think you should start them on baked milk before you send them to see us. Using the milk ladder accelerates natural tolerance induction. And the supervised single dose further accelerates this, probably by giving parents the confidence to succeed. These are a very anxious group of parents, as you all know. And that there is no immunological reason to delay introduction of tolerogenic forms of milk and egg. All forms of egg or milk below the level where the child has reacted are likely to be tolerated. In fact, delay is exactly what we want not to happen. It's likely to adversely affect tolerance acquisition. We want the foods in just in case, not out just in case, and do not delay them because you're coming to clinic. We want them in before they come to clinic. Medical time and nursing time equals HSE costs. Family time is money for the special feeds and for having to do special shopping. And cow's milk allergy can be treated at home without multiple hospital appointments. The learning outcomes to review these, I hope you are slightly more convinced now that early introduction is the target for every child. Don't suggest that they get screened. Don't send them for private allergy testing. The Nike doctrine is just eat it. There we go again, banging my head on that one. Immunotherapy for peanut is coming, and we have a very active immunotherapy program for egg and milk allergy in Ireland, and we are leading the world at the moment. We're having trouble getting people to believe what we're doing. Immunotherapy is safe at home for milk and egg, and sometimes for peanut. We didn't discuss peanut because this is mainly about infants here. So there's all our partners and people. So some of our sponsors and some of the people involved. And just finally, early introduction can take different forms, but it might not be necessary to do it quite like this. This is a real picture of a child where I said to Mum, you need to go home and give him some peanut. And she sent me in this picture the following day. I'm not sure I would do that because he's probably going to rub it into his eyes. But there we go. He got peanut in and seems to be happy enough with himself. So thank you very much.